Welcome, everyone, to this webinar on patient adherence and engagement in care in people with HIV. You'll notice that there are some demographic questions that have popped up on your screen. There are actually 4 questions, so please scroll down to the bottom and answer these. That's quite helpful for us to know who's actually attending the webinar. My name is Susan Buchbinder. I'm from the San Francisco Department of Public Health, and on behalf of the presenter, Dr. Michael Mugavero, who's a professor of medicine at the University of Alabama at Birmingham, we're really pleased to welcome you to this IAS-USA webinar. Could I have the next slide, please? These are the financial relationships with ineligible companies within the last 2 years from the content on the web board. And these are the financial relationships from the presenter, moderator, and planners and reviewers. We're pleased that there are 1.25 hours of CME credit as well as these other credits. So be sure to fill out your evaluation and claim these credits if you need them. We're really pleased to have this generous support for this activity from the following contributors. And this is just a reminder, you will get poll questions, and the separate window is going to show the poll questions, so please do answer those. Then if you have questions, we want you to use the Q&A button. And please be sure to use your full name and institution when you enter a question. The chat is open for discussion between attendees, but we will not be seeing those chats, so we will not take questions from the chat. So please be sure to use the Q&A button to enter your questions. And you can do that during the talk, and we'll get to the questions at the end of the session. So without further ado, it looks like we've got our demographic questions. So it looks like about 1/3 are doctors and about 1/5 are nursing professionals. We have a lot of pharmacists and other people as well. We have a number of people, about half, that are not seeing people under their direct care, but we've got quite a spectrum of other kinds of clinical practices. Then we see the proportion of clinical time spent caring for patients. About 40% are not spending time caring for patients with HIV, but the rest are. And then we've got some quite experienced IAS-USA webinar users and some for whom this is the first time. So welcome to all of you. And now we'll turn to Dr. Mugavero's presentation on patient adherence and engagement in care in people with HIV. We're very fortunate to have him as our presenter, as this is an area of expertise of his, and he also works on patient-centered care models and health disparities, and so we're very pleased to invite him to present.
Great. Thanks so much, Dr. Buchbinder, for the kind introduction, and really to the entire team at IAS-USA for the invitation and opportunity to spend some time with you this afternoon. And thanks to all of you for taking time out of busy schedules to hear some thoughts on where we are with engagement and retention in care, and really look forward to some discussion later on in the session. So the learning objectives for today on completing the activity is learners will be able to explain the nuances of measuring retention in care and broadly conceptualized as missed and kept visit measures. Describe different categories of evidence-based interventions that have been proven to improve HIV care engagement in clinical trials, but also to describe dissemination and implementation research and how this emerging area of research can help translate evidence-based interventions into our real-world clinical practices. So the first pretest question is here. A patient is scheduled for a routine primary HIV clinic appointment. In the last year, they attended 2 appointments that were more than 90 days apart and missed, no-show, 2 scheduled appointments. Based upon this patient's primary care attendance, which of the following is true regarding their risk of subsequent viral load, non-suppression, and mortality? Viral load, non-suppression, and mortality risk are both increased, neither viral load, non-suppression nor mortality risk is increased. Viral load non-suppression risk is increased, but not mortality risk. Mortality risk is increased, but viral load non-suppression risk is not. Okay, so looking at results, about 70% suggest that both viral load non-suppression and mortality risk were both increased. Others, about 20% viral load suppression and mortality risk are neither are increased. And then answer C, viral load non-suppression is increased, but mortality is not in 13%. And no one indicated the suggestion that mortality risk is increased only. Great. So on to the next question. So your clinic recently prioritized retention and care for a quality improvement initiative, and the medical director has asked you to spearhead a team to make recommendations for evidence-based approaches that your clinic might adopt as part of this initiative. Which of the following is an approach that would not be considered for the quality improvement initiative based upon guidelines and recommendations? Answer A is enhanced personal contacts before scheduled appointments. B, telehealth services, including two-way short messages, SMS messages. C, financial incentives for attending appointments. D, systematic monitoring of retention and care. Okay. So 71% would suggest that would not consider recommending financial incentives. About 16% would not recommend systematic monitoring, and then 6% each said they would not recommend enhanced contacts or telehealth services like two-way text messages. So this is great. So we'll come back to these questions at the end. So as an outline, going to start off with just operational definitions of engagement and retention in care. Then really address the question, does engagement in HIV medical care still matter in the modern era? Then look at some evidence-based interventions to improve engagement and retention in care, and then close out talking about the promise and the potential of implementation science. So I think part of the challenge in this field is there really hasn't been a consensus definition for what does it mean to be engaged in care. And for this presentation, operationally, think about three distinct domains as it relates to being people with HIV being engaged within their medical clinical care. Distinctly following diagnosis, the step of linkage to care, then longitudinal retention in care, and critically, the importance of re-engagement in care. So all of us caring for folks living with HIV, recognizing for a myriad of reasons folks can cycle in and out of care, so need to separately identify those who fall out of care for re-engagement. Similarly, for retention in care, there's not a consensus definition. I think linkage is somewhat easier. It's a dichotomous event. It happens. You could happen within a certain time frame. Retention happens longitudinally. And broadly speaking, retention has been based upon measures that have been used, both missed visits, typically no-show, where someone hasn't called ahead and canceled, or kept or arrived clinic visits as broad conventions and categories. By convention, the research has really focused upon scheduled HIV primary medical appointments, recognizing the importance in that many times people with HIV have other subspecialty, laboratory, case management, and other appointments that really, in measuring retention, it's focused on that primary appointment with that primary medical care provider. In many instances, especially with surveillance data, biomarkers, CD4 counts, and viral loads have been used as a proxy for kept and arrived visits. And as we all know, folks can get labs in a number of different settings. So not a perfect proxy, but where those data are available have commonly been used as a proxy for an arrived or an attended visit. So my colleague, Tom Giordano at Baylor, has been a thought leader for several decades in this space. And I think this table he published, not a lot's changed in the last decade plus. Thinking about how to measure retention and care, a number of measures have been operationalized and used in the literature. And then kind of breaking down, as I said, broadly, do you need missed visit data to calculate them or not? And how easy is it to calculate them based upon what goes into it, and how long does it take? So a number of different measures. I think critically, one of the take homes here is that for those who are working in clinics, clinics are uniquely able to capture and measure when someone misses a visit. So our measures that are based upon arrived visits, using things like viral load and CD4 as a proxy and looking over longer periods of time, aren't able to capture, whether or not someone made it to that scheduled appointment. So some of the earliest work, with this idea of, broadly speaking, kept visit or arrived visit measures was Tom and colleagues, Giordano, looking at survival and people with HIV in the VA health system. This is back in an era where we were seeing folks, every 3 months. So quarterly was the standard of care when this was published back in 97 to 98, and really asked a very simple question: that among persons with HIV in the VA health system, we're going to observe folks for 12 months and just ask the question, how many quarters, calendar quarters, did someone have at least one arrived visit? And what you could see clearly in the table and in the Kaplan-Meier plot was, relative to those persons who came for a visit in all 4 quarters, there was a dose-response relationship, that people who came in 3 quarters or 2 quarters or 1 quarter had increased mortality relative to patients who came in all 4 quarters. This is some of our earliest work with missed visits and no-show visits. So a really simple question looking at patients coming to our clinic as new patients, 543 persons from 2000 to 2005, and simply asked, if someone had a no-show visit in the first year and started a survival clock, what was their risk of long-term mortality? And what we saw was that for persons who had a no-show visit, there was nearly a 3-fold mortality risk, almost as high as coming in with a CD4 count below 200. And even when controlling for things like age and viral load and whether or not therapy was started in the first year. So a really important early indicator for us in the clinic that folks who are missing visits, are telling us they're at increased risk for longer term mortality. And we have the responsibility of trying to understand why and what can we do about it. And in the last many years, missed visits have been associated with a number of different, poor health outcomes across cultures, across contexts, including delayed ART start, worse retention long-term, taking longer to suppress virus, cumulative virus, disparities in suppression, hospitalization, mortality. So really consistently, when you look at studies, see these associations across different settings: more missed visits, worse health outcomes. So when comparing retention measures, and this is an older study but was replicated recently, and kind of looking at how do they compare to one another, this was 6 academic clinics who participated in the CDC trial for retention and care. And this was data captured before the trial was launched, and categorized people with HIV over a 12-month period, using the same visit data, the same data on how many visits were attended, how many were missed, the timing of those missed visits, to derive these different categories of retention and care. And what we found was that in the Spearman rank correlation, the measures of missed visits were very highly correlated with one another, 0.84, 0.85, correlation. The kept visit measures also highly correlated, although not as much so, but pretty high correlations. And what was really interesting in this early study was that when you looked and compared measures of retention and care based upon missed visits and those based upon arrived visits, the correlation was very low, and suggesting that these things are different. They're capturing something different, and that there's differential potential value in these 2 different types of measures. They're not capturing the same thing. And so with that same study, we went on and said, despite the appearance that missed and kept or arrived visit measures are capturing different things, different domains, all of them were significantly and strongly associated with viral load suppression. So in this study of 10,000 persons, again, dated, but the idea that, whether you measured retention by missed visits, arrived visits, the nuance of these different measures, clearly there were strong and significant associations with viral suppression. So go on to talk about, I think as the field evolved, this was some really elegant work looking at different patterns of retention in care among persons with HIV in North Carolina, and could see, based upon visit profiles consistently high, retained, folks who did well early on and declined, folks who got off to a slow start, but then their retention improved in the blue line, the late increasing in the orange, and then the consistently low engagement in care. So I think as a field and scientifically, a lot of really elegant studies and good epi work, trying to understand these different patterns. And then just, fast forward a few years. So the continuum 2019, and, I think we saw that retention in care was at 50%, whereas viral suppression was at 57%. And I think for a lot of people, and what I heard a lot and still hear a lot is, does retention in HIV medical care still matter? If the goal is viral suppression, and if we're achieving 57% viral suppression, retention is lower than that, like, does it really matter? And I think this is something that's been discussed and debated, and I hope after the presentation today, you will agree with me that it does still matter. So, now kind of go and show some more recent evidence, looking at data, indicating the role of retention in care as it pertains to health outcomes. So several of the studies I'm going to share are from the CFAR Network of Integrated Clinical Systems, or CNIC. So these are 10 academically affiliated HIV clinics that are all across the country. So not necessarily representative of all the places persons receive care, but a robust database that's captured systematic data, including visit data, for over 2 decades. So a very robust database and source of data to study at scale and across the nation patterns of retention in care and impacts on health and health outcomes, among a wide range of other scientific areas. So a study that was just published earlier this year, where there's 2 separate models kind of asking, does retention in care still matter? And looked at 2 different models in 2-year sustained viral suppression based both on missed visit measures and kept visit measures. And what we saw was still a significant and strong association, so that even in more recent years, persons in care between 2017 and 2020, 11,500 individuals, persons who had, more missed visits measured by adherence had a dose response relationship of being less likely to have sustained viral suppression over 2 years. Similarly, the National Academy measure, or HRSA measure, of attending 2 visits in 12 months, 90 days apart, failure to achieve that measure was also associated with a 20% reduction in sustained viral load suppression. So, based upon more contemporary data, missed visits, both by missed and arrived visits, retention in care still having associations with viral suppression. Dr. Katie Lesko at Johns Hopkins in CNICS did another study, and she said, instead of looking at them separately, let's look at these 2 things together. And so looked at the odds of viral non-suppression and 2-year mortality among people with HIV and CNICS from 2010 to 2018. Over 20,000 persons, over 100,000 person years of observation. And the data she looked at, so she looked at the groups that were retained by both a missed and kept visit measure, or that were not retained by both. Those data are as you would expect. People that were retained by both do the best, that were not retained by both do the worst. What Dr. Lesko and team did was look at that kind of off diagonal. So in that second column, persons who were not retained by a kept visit measure, they did not come to 2 visits 90 days apart, but they were retained by a missed visit measure. They hadn't missed any visits. And what they observed was that for people who came to 2 visits 90 days apart, so were retained by that measure, but didn't miss any visits, that they did have an elevated risk of viral non-suppression, but didn't have an impact on mortality risk. In the other group, so the persons who did come but to 2 visits that were 90 days apart, but not retained by missed visits, so they actually had missed more, 1 or more visits, there was a strong association with both viral load non-suppression and mortality. So the idea of, even if someone has come to 2 visits more than 90 days apart, there's something about those missed clinic visits. And again, I don't think it's the missed clinic visit themselves, but as a marker, as a powerful marker that's indicating this is somebody who is at greater risk for both viral load non-suppression as well as for subsequent mortality. Here, 2-year mortality, relatively short term. So Dr. Lesko and colleagues went on to look at factors that were associated with suboptimal retention and care, and found that some of the factors associated with less optimal retention and care were younger persons, Black non-Hispanic persons, and persons with a history of IDU. And I think really importantly, this has been true from the outset with the work in retention and care. They said we would be bereft if we did not acknowledge the disparities in retention, that monitoring retention according to missed visits might therefore be thought of as an equity issue. So not just a health outcomes issue, but a health equity issue, and really pointing to the role of missed visits based on those findings, that even when folks are retained, that by coming to multiple visits, missing still carries some value in terms of predicting higher risk of viral non-suppression and mortality. So I come back to Dr. Giordano's chart, because I think for those folks who are working in clinics, the thing about missed visits is only those in clinics capture them. It's easy to calculate it, and you could do it immediately. So some of the measures that we use, and they're really important as quality indicators to measure apples to apples and oranges to oranges. But for example, measures of retention and care used for the continuum or the cascade take 12 months to calculate. Ask if someone attended a certain number of visits, don't account for missed visits. And while valuable for quality indicators and to give us a population level, a lot of times if you wait 12 months and calculate something and you want to then act and reach out and try to kind of bring someone back in, it's hard to contact them. It's much harder to re-engage someone that's lost than to kind of keep somebody in care that's tenuously engaged. So the point of this slide, especially for folks in clinical settings, is, as resources allow, as there's programs available, the missed clinic visit is a really powerful indicator that someone is at higher risk to not do well. And it's something that we uniquely capture in clinics. It's easy to calculate it, and we know and can act on it in real time. And again, from the Lesko article, they concluded that missed visit measures of retention and care appear to be more strongly associated with subsequent viral load suppression and mortality than measures based on kept visits. Both have value, both have roles, both associated with non-suppression, but again, pointing out this unique value and enduring prognostic value of missed clinic visits that are really telling us something about our patients. And I think in inviting us to understand what about the context of someone's life, or what are the factors that are driving that increased risk for non-suppression and mortality. So, want to be clear, not suggesting the missed visit is causally associated with the mortality, but for us as providers, doctors, nurses, pharmacists, social workers, patient navigators, when someone is missing appointments, they're telling us that there's something going on that is going to increase their risk for poor health outcomes longer term. And so, importantly, in terms of contextualizing care engagement, and this is from the HIV/MA primary care guidelines, that it's really important for us. And one of the pre-registration questions asked about social and structural determinants, and are critically and vitally important. I think sometimes when we talk about missed visits and no-show visits, there's a suggestion of, are we blaming people? And I don't think that's the case at all. I think it's recognizing there's a marker, but there's a myriad of factors at multiple levels that are influencing someone's ability to come to their regularly scheduled appointments. And things like housing instability or food insecurity or transportation limitations, as well as, experiences of stigma and how someone is received and treated in the clinic and in the community. There are so many factors at so many levels that influence that single measure of folks, attending their regular medical appointments. So going to transition now and talk about some of the evidence-based interventions to improve engagement and retention in care. And, I think part of the challenge, in the field is that there have not been any like silver bullet magic interventions. I think those of us working in this space, working with clients, with patients, realize it's really hard, and that we don't get the effect sizes for retention and care that we see with long-acting injectable PrEP and other kind of interventions, that a lot of these interventions are hard to do, don't give us the kind of same big effect sizes. But again, I'll argue that it's really critically important that while they're hard and might not give us the same, effect sizes as pharmacologic interventions and others, they're vitally important if we're going to really achieve and optimize both individual health outcomes and also our population health outcomes in reducing new infections. So, we can look to the HIV-MA guidelines. So it's really helpful, I think. The guidelines have a great section, the first section, about optimizing care engagement, medication adherence, and viral suppression. And what they did, they summarized nicely interventions that improve care engagement generally achieve one or more of three things. So they achieve care coordination through a multidisciplinary team or providers and social support, provision of an essential need, such as housing or food assistance, so addressing those social and structure determinants, or creating an environment that elicits and acknowledges patients' goals, motivations, and care needs. So this idea of patient activation, patient engagement, within our systems, creating structures and environments that really engage them and are responsive to their individual goals, motivations, and care needs. The Department of Health and Human Services guidelines, when they talk about adherence to the care continuum and key considerations, talk about the importance of monitoring, regularly assessing linkage to care and adherence to ART. Again, similar to HIV-MA, the importance of a multidisciplinary approach and collaboration with an interprofessional team. And I think we're really lucky in the HIV care space, in large part because of the Ryan White program, that we have such robust interprofessional teams caring for our persons with HIV. Persons having difficulty should have additional adherence supports, constructive, collaborative, non-judgmental, and problem-solving approaches. Importantly, this is in the DHH guidelines. They say that evidence does not support the use of financial incentives to engage people with ongoing with HIV and ongoing routine care in the U.S. And so the Department of Health and Human Services in their Table 20 also talk about some of the strategies that are suggested and recommended based upon the evidence to improve linkage retention and adherence to appointments and therapy. So, they suggest that some of the strategies, for retention and care include enhanced personal contact and personal outreach, the use of community health workers, the use of patient navigators, enhanced clinic support and structures, for example, reminder calls and telehealth services, and the evidence behind that. Also, the importance of systematically monitoring retention and care. So a recommendation from the Department of Health and Human Services, from Table 20, we should be, as a system level, recording and following up on missed clinic visits. So again, I alluded to this, as we moved into this section of the talk, there really are a paucity of evidence-based interventions that have been tested via vigorous designs. When we think about the amount of data and science and studies comparing different drugs for prevention and treatment, really a paucity of evidence-based interventions. And most interventions have been evaluated through demonstration projects or with quasi-experimental design. So not as many kind of rigorously designed randomized control trials. Most interventions that have shown effects have small to modest effect sizes, as I said earlier. So there really hasn't been anything that's given a really big and robust effect size as a way to dramatically improve. It's probably going to take doing a number of small things to increase those bigger improvements. A majority of the studies, when you look at it, have been done globally in low and middle income countries. There's been much fewer studies that have been done domestically. I will say that nearly all successful interventions have a human component. So in some form or fashion, there's some individual who's involved in some way connecting with that patient and trying to retain them in care. And increasingly, and many interventions do have a technology component. So I'm going to run through some of the evidence-based interventions that exist, just to give some examples. This is one of the earliest. Our site was one of the 6 academic HIV clinics that were involved in this enhanced personal contact intervention. I will say one of the really cool things about this study was it was a partnership between the Centers for Disease Control and Prevention and the Health and Resources Services Administration, HAB. So CDC and HRSA HAB co-sponsored this project. It was a randomized trial enrolling over 1,800 persons with HIV in clinical care who had a previous history of missed visits and poor retention and care. And the enrollment period was 2010 to 2012. And there were 3 study arms. So there was enhanced personal contact plus 2 skills building session, and the standard of care session. And the outcomes, there was a visit adherence, a missed visit measure, and a visit constancy, and a kept visit measure. And we'll say for research purposes, I think most folks in the field still recommend for research purposes value in studying as outcomes both a missed and a kind of kept visit measure in the research space. The schema for enhanced personal contact calls, prior to and after missed visits was, a enhanced call about a week and 1 to 3 days before the appointment and within 2 days of a missed appointment. And it's really important that these are not robocalls. These are not remind them calls. These are not calls from a random person. So this is an interventionist who is trained in motivational interviewing skills, who works within the clinic, who works for the clinic, who the patient can identify with, who's calling both to remind about the call the next week, and again in a non-judgmental and reassuring way, but also to ask about what barriers might exist to coming into clinic. So and then kind of handing off to the right team member if a barrier is uncovered, or if it turns out that someone can't make an appointment, let me help you cancel and reschedule that appointment. And then the missed appointment call, similarly, not calling out to say, why didn't we see you, but what happened? You missed your appointment. Are you okay? And how are things going? And how can we get you back into the clinic? So a relatively simple, at the time, all phone calls. I think now we think probably, texting, other ways of communication might be more effective, but this was the design of this study, about 15 years ago. And what the study found was that both the enhanced personal contact as well as the 2 skill sessions was superior to standard of care. And a 5% difference in visit adherence, so not insignificant, difference in visit adherence. The enhanced personal contact and skills building were lumped together because those 2 skill sessions really didn't add to the outcomes. They had very similar findings. So for purposes illustratively lumped together because they had very similar outcomes. Importantly, certain subgroups and some of the groups that Dr. Lesko had pointed to as having greater challenges with retention and care, the intervention seemed to be effective in Black African-American patients, women, and those who were insured by Medicare and Medicaid. It was not efficacious in youth, in substance use, and persons with unmet needs. So I think the indication that there are certain subgroups that a relatively light touch reminder intervention isn't going to be enough and going to need more. And not surprisingly, there was a dose-response relationship between successful enhanced contacts and visit adherence. So you could see if the interventionists weren't able to make any contacts, those persons had 55% visit adherence, where if they were able to make 7 or more over the course of the 12-month intervention, it jumped up to 77%. So not surprisingly, the more success in those personal outreach, the more success in folks having better visit adherence. So the next study I'm going to touch on was a pilot of this Project Engage, and it was a randomized controlled trial at 5 HIV clinics in Chicago. Enrolled, 98 persons between 2012 and 2015. Focus was on young African-American MSM and had 2 study arms, an intervention arm, and the intervention was a dyadic support confidant. So really importantly, what this study did was identified someone within someone's existing social network to be their support confidant. I think a lot of times when we do interventions, we realize when we bring in an exogenous or outside interventionist, it works for the study, but then it's really hard after the study funding ends to kind of keep that going. So the approach was, can we find somebody within someone's social network to be the support confidant and work with their social worker to develop a care and support plan, delivering 4 telephone boosters with that index individual and compared to the treatment as usual. And as a 12-month outcome, they evaluated if someone attended 3 or more visits in a 12-month period. And in a multivariate model for retention and care, again, 3 or more visits during a 12-month period, there was an indication of a substantial increase in the odds of being retained in care in the intervention versus the control arm. So a fully powered trial of Engage is ongoing, and we'll look forward to those results. But I think a promising intervention leaning on someone's existing social support in their network plus their social worker in a way I think that could see how this could be possibly scaled and sustained without additional resources to hire additional interventionists if this Engage is promising in the larger trials. a lot of interest and questions about telehealth interventions. And so I will point to this narrative review, was published again relatively recently, earlier this year. And so they looked at manuscripts that were published between 2019 and 2023 and found 23 different interventions. And a number of different telehealth modalities were utilized. You can see in the table, and some used multiple. But common was text messaging, video conferencing, using existing commercial apps that were already off the shelf. Developing novel multi-feature apps were done by 22%. Using existing electronic adherence monitors, that was for ART adherence, social media apps, and some using computer-based or internet-based programs that were novel and developed. And 7 of these studies of the 23, retention and care was measured. So some of the others were for linkage or re-engagement in care. And I will say, when you kind of take them in totality and try to digest, these 23 studies, the studies of two-way text messaging coupled with some personal component, so sometimes behavioral therapy or community health worker, technology plus a person, look to be the most promising. And the two-way text messaging being really critical. And we saw this, years ago with the WellTel project globally. Just pushing messages and reminders typically is not enough. Sharing information with a chance for the individual to engage with who sent the message really being critical for the success of text messaging interventions. And best if that person, is a known person. I'm going to move to one study in Kenya, and it's less about the findings and more about the design, because I feel like as a field we need more designs like this. So this is the sequential multiple assignment randomized trial schema. And so this is the schema on the right. And so what happens is you start off and you randomize individuals to either intervention A and standard of care or 2 different interventions. And then at a pre-specified time point with a pre-specified outcome, you determine, did someone achieve or not achieve that outcome? So if we did an enhanced contact intervention, and in 6 months we say, did someone miss visits or not miss visits? In the responders, so no one missed visits, you keep going with the same intervention. Or in the non-responders, you re-randomize them to a next intervention. So the idea is we're starting with something. If people respond, we kind of keep that going. If they don't respond, we re-randomize. And in many ways, this can be thought of as a strategy kind of design. So we're starting with something maybe low cost, a little bit easier. If it works, then we kind of keep it going. If it doesn't, we move to a more intensive, more resource intensive approach. And so this was a really elegant study that was done by Elvin Gang and colleagues with 3 study arms: SMS messages, conditional cash transfer, financial incentives, standards of care, and was the initial randomization. So they had ABC, and then for non-responders, they re-randomized to outreach, conditional cash transfer, and peer navigation. And so again, if people responded, you continued. If they didn't, they would be randomized to stop. They ultimately ended up with 15 different sequences. And for this study and this global population in the setting, the conditional cash transfers, followed by a navigator for those who failed, or for continued cash transfers, had an average effect treatment size. So a 7.2% effect size in improving retention and care, an 8.2% overall increase in viral suppression. So again, not as much about the findings, but about the need for us, domestically to do more studies like this that are studying strategies and the sequence of things to really understand. Because I think in practice, that's how we approach things. We try something, it doesn't work, we try something else. So I hope that in the years ahead, we'll see more retention studies using designs like the SMART design. So, again, urgent need for more evidence-based interventions. We need traditional RCTs. I'm going to argue that we also need SMART designs. MOST is another with factorial designs. Won't go into the details of the MOST framework, but holds a lot of potential to help us optimize. Instead of just studying A versus B or A versus standard of care, being able to tease out different components and the relative contribution of components. And as I said, when we're getting modest incremental improvements for components, really studying and understanding which ones work and how to put them together, I think is going to be critically important for us, as well as how to sequence them over time. And then hybrid and implementation trials will be really important going forward. So gonna close now, with the promise and the potential of implementation science. And so this is one of my favorite, and it's one of the earliest times that I could find dissemination implementation science in the literature. And Lomas, published back in '93, right, over 3 decades ago, that it's not merely enough to publish information and hope that it gets disseminated. That there's a handful of findings that are so compelling that passive diffusion works, and you don't need the rest of the dissemination implementation. But went on to point out there aren't many penicillins left in the world. There's not many things that you do the trial, you publish it, even you publish it in New England Journal, that you change practice. Maybe for some therapeutics, but for behavioral interventions, it typically is going to take a lot more than just publishing the results to really kind of change practice and change policy. It's been around for a long time, implementation science, but I think in the last several years has really increased in importance and kind of the mainstream. So this was in JAMA a few years ago, and talks about this frequently cited estimate that there's a gap of 17 years. It takes 17 years from when we discover something works till it's actually delivered in routine care and routine practice. And beyond that, only about 1 of 5 things that we show in a trial to be efficacious, make it into routine care. And the field of implementation science is really trying to speed things up and close that gap. So, a schematic of the different trial designs, efficacy studies are our classic randomized control trials. Effectiveness is saying, how does something work in a more real world setting? So in efficacy studies, we often will have more strict exclusion inclusion criteria. There's more control. Effectiveness is taking those same interventions and loosening some of those criteria and moving it to more real world settings. The hybrid designs are really interesting. So implementation research is more studying, how do you take these things and put them into practice? And the hybrid designs have become very popular because you're simultaneously evaluating both the clinical effectiveness, but also how these different implementation strategies you're using, how effective they are. And a type 1 to a type 2 to a type 3 is simply, are you focusing on the clinical effectiveness outcome? Are you focusing on the enhanced personal contact intervention to improve retention and care? Or are you focusing on the reach and the uptake of those things? So type 1 focusing more on the effectiveness, type 3 focusing more on the strategies and the reach and the adoption and the uptake. And hopefully this will become more clear with the next slide. So Jeff Curran published, this IS made too simple. And I think it's really helpful because as a field, I think some of what's limited implementation science has been acronyms and jargon, and sometimes can be hard to wrap your head around. And, Curran broke it down really, simply to say the intervention or the practice or the innovation is the thing. It could be a drug, it could be a telehealth, it could be a behavioral intervention, but that's the thing. And when we do effectiveness research, we want to know, does the thing work? Does the thing improve retention and care? Does the thing reduce missed clinic visits? Implementation research is saying, how best can we help and support people and places and practices to do the thing? And if those implementation strategies are the stuff that we do to try to help people and places and practices do the thing. So our implementation outcomes are, how much is a site doing the thing? How well is a site doing the thing? How well are they sustaining the thing? So we know the intervention works, but we're doing different strategies and trying to figure out how well they can kind of take these things and implement the things that work into practice. Re-aim is a really common evaluation framework, and I think it kind of can help. So we're kind of, what is the reach? So this is in implementation science research. What is the reach? What is the number of people who, actually in my target population that received the thing? The effectiveness, as I said, we want to know, did the intervention work? Did it have an effect on the clinical outcome, the missed visits, the retention and care? The adoption, we trained a bunch of practices. To what extent did practices and providers deliver the intervention? What was the adoption of actually delivering the thing? Is it done consistently and with fidelity by staff members? Is the implementation and the maintenance? is this part of routine care and practice over time? Are we continuing to deliver this innovation, and how much and for how long, and who's receiving it? So just kind of a breakdown of what's being studied and what's being measured by implementation research relative to kind of traditional clinical research. Want to point out that in the last 5+ years, NIH has invested in a robust HIV implementation science infrastructure. So there are currently at these institutions these different implementation science regional consultation hubs, and so they span the nation and are really there to support NIH investigators in conducting implementation science trials, especially in line with the ending the HIV epidemic paradigm, which treat for retention, engagement, and care squarely fits. So a really substantial investment, including funding to our site at UAB. This was established back in 2018. There was an inter-CFAR working group, and in 2019, NIH funded Northwestern to establish this implementation science coordination, consultation, and collaboration initiative hub. They held a summit, brought in 65 partners, including clinical and community partners. In 2020, expanded and brought in 5 regional hubs, and then kind of carried this on through 2023. But these hubs collectively supported nearly 250 EHE supplement projects to CFARs that were doing hybrid and implementation science studies. So, won't go into the details of this, but over time, almost 250 projects in implementation science, and many of them focusing on the treat pillar. And I say this to suggest, I think we are going to, in the next several years, see a lot of this science come to fruition, come to publication, in helping us, build not just what works, but how do we do it and how do we sustain it in terms of really trying to support engagement and retention in care. For folks that are interested, there's been a number of supplements, dedicated themed to implementation science. In 2022, one that was informing strategies. In 2025, one with the progress and priorities. Again, I think this provides us a foundation. It describes this infrastructure. And now we're at a point where, I think as the science increases and there's more funding opportunities, we'll see the emergence of implementation science and strategies to help us in our clinics and practices identify and select the most promising interventions that fit with our population, with our clinics, with our workflow, with our staffing, and hopefully be able to kind of start narrowing some of the gaps and improving retention and care. And I think, more recently, August 15th, the NIH mission and through this unified strategy, it's been, an interesting landscape with NIH and navigating. I think for those of us in the field of HIV research, one of the things that was highlighted was implementing advances in HIV/AIDS research. So, despite a lot of volatility, uncertainty with federal funding, clearly there's been looking to take advantage of this opportunity to support implementation science to increase the uptake and access of existing medical and behavioral interventions that can help limit and eradicate HIV in the US. So I think we're going to be seeing more of this kind of research going forward. And I think this is the kind of research we need, to go, as Loma said, beyond publications to really get to, our practices and improving real world population health outcomes. So to summarize, I hope that, despite the most recent cascade continuum, that most folks will agree that retention and care still matters. From a research perspective, like it's very nuanced, and I think I get that. And some folks maybe were put off by that, when it's on the research side of things. But broadly speaking, we're talking about missed visits and kept visits. And I think there's ways to do that effectively in routine practices outside of the research space that makes sense, both for reporting, for quality indicators, but also, again, I would argue strongly that, measuring and acting on missed visits as clinics as there's resources is one of the best investments that clinics can make. Missed visit measures consistently, for over a decade, the recent Kay and Lesko papers have prognostic value for viral suppression and mortality. We don't have a ton of intervention evidence for retention and care, and the effect size are modest, but there's some, and almost all of them have a human component and many a technology component. again, I would strongly encourage the need for more rigorous retention and care intervention trials and the need for novel designs. I think SMART to help us with kind of, strategies over time, and MOST to find the best combination of components and not just test, everything versus nothing, really are going to be important for us as the field moves forward. And also some reason for hope. Again, a lot of challenges with the current landscape, but that the NIH's infrastructure for EHE research and portfolio and kind of commitment to implementation science towards EHE holds some potential in the years ahead. So with that, again, we'll thank folks and we'll come back and back to the post-test questions. Okay, great. So looks like 84% answered that both viral load non-suppression and mortality risk are both increased. And that's the correct answer. So 84%, the correct answer, answer A. So, we have more than a decade of research that have evaluated these different patterns of primary care appointment attendance and have consistently demonstrated that there's these two broad categories: kept or arrived visits and missed or no-show visits. And this patient had arrived for 2 visits more than 90 days apart, satisfying that HRSA had measure, a National Academy measure for retention and care. So you could say they were retained because they hit that kind of benchmark and that quality indicator. But they also missed 2 clinical appointments. And, although missed visits are not included in our kind of national indicators and quality measures, consistently have been associated with viral load non-suppression and mortality risk. And the recent study by Lesko and colleagues, I was a co-author on that study, demonstrated that even among people who attended 2 or more visits separated by 90 days, those that had missed visits still, despite coming to 2 visits in a year, had a higher risk for both viral load non-suppression and mortality. Great. And so again, this was just pointing to that data from Dr. Lesko, so that even people who were retained, came to 2 visits more than 90 days apart, but missed visits, they had an elevated viral non-suppression and 2-year mortality risk. So the second post-test question. Okay, great. So 77% say financial incentives, and then kind of roughly evenly split between the others. And so looking at this, that's 77% got the correct answer, answer C. So the HIV/MA primary care and DHHS guidelines include sections for engagement and retention. And while there's a paucity of rigorously tested interventions that have been studied and included in the guidelines, they do highlight the importance of systematically monitoring retention and care. Specifically, the DHHS guidelines suggest both monitoring, but also following up or acting on missed visits when there's capacity. They also recommend deploying evidence-based intervention. So enhanced personal contact that we shared, the telehealth services shared that recent narrative review, and the HHS guidelines also indicate that there really is not evidence to support the use of financial incentives to engage persons in care with HIV and ongoing care domestically in the US. And again, so this is from that DHHS guidelines, that table, the idea of enhanced outreach, patient navigators, support structures, telehealth services, but also systematically monitoring retention and care, recording, and following up on missed visits. So with that, I will stop sharing again, want to thank you all again for taking time out of busy schedules to be here today, and look forward to some discussion and some questions. Dr. Buchbinder.
Great, thanks, Dr. Mugavero. And that was really an excellent, very clear and comprehensive overview. So please do put your questions into the Q&A component. Be sure to include your full name and affiliation, and we'll start with the questions that are coming in now. We have Christina Manasian Hunt from Dartmouth Health in New Hampshire, who asks, is there any research that distinguishes between distinct interventions for distinct populations? For example, contingency management has a good body of research behind it for people with stimulant use disorders, who may also be seen in our HIV programs, but other interventions may be more appropriate for individuals who do not have stimulant use disorders.
Yeah, no, it's a really great question, and thank you for that. So there certainly have been intervention studies focusing on subgroups and subpopulations, including for folks with substance use disorders, opiate use disorders, stimulant use. And so I think, looking at the literature, even in the populations and with, there's been integrated care models and small pilot and demonstration projects that have shown promise, but they're relatively small. I mean, looking at integrated care, integrating treatment within the context of, substance use treatment and HIV treatment. The Max Clinic, a really, Julie Dombrowski and colleagues in Seattle, high touch, high resource clinic, very effective in a population where 85%, had substance use disorders. But I think some of the challenges have been, how do you scale that and sustain that? So comprehensive services, including contingency management, as well as a bunch of other wraparound services, in that demonstration project of Max worked. But I think some of the challenges have been outside of our, with our current financial models and reimbursement models, replicating clinics like that have been challenging. I would point to a few studies led by Dr. Lisa Metch as well. So there was Project Hope and Project Retain more recently. And in those studies, and again, persons with substance use disorders hospitalized, there were some modest benefits at the time of delivering contingency management in the context of patient navigation or outreach. I think part of the challenge was, once those financial incentives were no longer provided, oftentimes the continued improvement in the kind of health outcomes did not happen. So just questions around long-term sustainability. So a very long answer to the question, I think, about both, yes, studies in subpopulations and subgroups that exist. And again, went into more detail about specifically persons with stimulant and other substance use disorders, because I think those are some of the comments too we saw a lot from the pre-registration questions. So wanted to make sure to touch upon that.
Great, thank you. So Debbie Sestaro, who's a quality improvement consultant, raised the question that patients often report that callers from the clinic call them using different phone numbers, so they don't answer the calls that are made to enhance personal contact. So that's a challenge. Stigma is reportedly high for these individuals. And as HIV care moves into the realm of chronic disease management in community health centers and FQHCs, it seems that it'll be more important than ever that we optimize collaboration with community providers and services in our communities to support personal contact strategies to improve health outcomes for people with HIV. And she wanted to know your thoughts about that.
Yeah, I think there's a lot of really good points there. And I do think it's interesting. I think there's different models, and there's certainly models where HIV care is provided in the context of community health centers. I feel like, despite discussions for quite a long time about HIV care increasingly as a chronic disease moving into more primary care and FQHC models, a lot of persons are still receiving their care in specialty clinics. And I think that's been just an interesting observation over time. But I do think, in terms of enhanced contacts in the context of routine care, it makes sense. I mean, so thinking about this when community health settings, I will say, working with colleagues in recent years on taking the same enhanced contact interventions for persons with hypertension, persons with diabetes. I mean, I think the idea of those touches being really important. I think really good points. I mean, I think people are very reluctant oftentimes to answer calls, from numbers they don't know. So when thinking about enhanced contacts and calls, is there a way to make sure they're identifiable so someone knows who it's coming from and is more likely to answer? And it's interesting. We had our quality group met last Friday, and we talked about, we had taken that enhanced personal contact intervention and done it, and said, people kind of, would get frustrated, like, why do you keep calling me? But that it actually across our quality group increased retention and care. So I think a lot wrapped up in, the calls and how long and how much, but some really great points there, and how we integrate this within primary care and community health settings. I think is constantly evolving, but it makes sense. I mean, to think about HIV in the context of how we manage other longitudinal chronic diseases.
Great, thank you. We have another question from Jupsa Sandrine from the University of Rome, who asks a couple of questions. One is, how can healthcare systems strengthen patient engagement in HIV care beyond just medication adherence to include psychosocial and community support?
Yeah, I think a really good question. In terms of psychosocial, I mean, I think part of the importance in thinking about psychosocial support and linking with community support is needing to ask. I mean, so I think, in terms of how we're identifying, if we don't ask about psychosocial need and what, it's hard to address. I think we do to a certain extent through Ryan White clinics domestically in the US because of reporting requirements, but really systematically, and some sites have moved to patient-reported outcomes and questionnaires to identify what might be psychosocial needs that we just don't know about because it's not coming up in the context of our interaction. So I think an important thing to consider is, and again, we worry about patient burden and how much we're asking folks to do, but if not systematically screening for factors like depression, anxiety, substance use, alcohol use, potentially stigma that we know have an impact on how persons engage with care and adhere to medications, I think a starting point is just systematically measuring and monitoring. I mean, so we can identify. And then oftentimes it comes to how do we link to, the clinical and community resources. And I will say very early in doing this work, realize there's oftentimes, a lot of limits to what we can do within the four walls of the clinic, and that a lot of what influences someone coming to their visits happens in their day-to-day lives outside of the context of the healthcare setting. So have always been a really strong proponent of forging those community partnerships when oftentimes community agencies can provide services and provide them in a way that we can't in the clinic, that can address some of those barriers, be them social or structural or otherwise, to folks regularly attending their appointments.
Great. There was another question that was also asked about whether there are differences that you've seen in terms of what works for adherence and retention in developing world settings compared to developed world settings.
Yeah, it's interesting. I think there's a lot of interest now, and I think it's going to be interesting over time, just as this emerges in reciprocal innovation, studying the things that work across different settings. There's something that works in low and middle income countries and work in US settings. A lot of times I find, the systems of care are so different that the way the interventions are designed can be very different. So just such a different way of practicing and kind of the expectations in terms of frequency of visits, getting medications, doing things. So, certain models that have worked, internationally, I haven't seen even tried here in terms of like having adherence groups and someone going and picking up medicines for the group rather than all the folks going. So, there's certain things I think that don't translate because of just the context and the kind of how care is delivered. I think in other things, there's a lot of things that do. I mean, so a lot of the work on two-way text messaging, for medication adherence, Lester's WellTel study started in the low and middle income, country setting. So I do think there are a lot of strategies. And again, at the end of the day, I think part of what's hard, technology alone, I don't think is going to do it. I mean, there's always some human element and human component, but I think broadly speaking, in one setting, it might be a navigator or an outreach worker or a traditional healer. In another setting, it might be, someone with a different skill set. But I do think across settings that a role for technology is very real, but there's this very real human element when we're talking about working with people and human behavior.
Great. Debbie Sestero also asks, what are your thoughts on systemic neurocognitive screening in people with HIV? We're finding as people are aging with HIV that some are having difficulty maintaining viral load suppression and coming to appointments because of neurocognitive issues.
Yeah, no, great point. I think a really great point, and would say again, where there's capacity, resource, and not putting too much burden on patients, I do think, at some frequency, neurocognitive screening, because a lot of times, when things manifest in a clinically observable way, we've missed an opportunity when someone might have more subtle neurocognitive challenges. So would certainly advocate for where it's feasible at some interval, whether it's through a patient reported outcome or through a cognitive interview. I think really important, and especially for our growing number of persons who are aging and with HIV.
Great. And then Lucia Torian from the New York City Department of Health and Mental Hygiene asked, what are best practices for keeping patients engaged in care when they're asymptomatic and on ART, but having difficulty with compliance and therefore achieving and maintaining viral suppression? So the challenges of asymptomatic infection.
Yeah. They're on ART, but having difficulty with compliance. Again, this is where, I think leaning on our harm reduction strategies, I could think about, just this idea of, I think this human and technology component. How do we just kind of keep connected with people? And, even if they are not able to achieve and sustain suppression, but we are trying to kind of reach out with them, connect with them, keep them in care. And if a viral load of 1,000 is the best they can do, let's celebrate that as being successful as we're encouraging them. But I think, we saw historically, before, in the era where we waited for CD4s to drop before we recommended treatment, that very early on, the asymptomatic folks not receiving therapy would oftentimes drop out of care and would come back with OIs later on. I think in the contemporary era, for folks who might be asymptomatic but are having a hard time with compliance and adherence, I think it's those same kind of, in most settings, some two-way text or some telehealth with some human component. If there's resources, the Max Clinic is an amazing model. A high intensity, low threshold clinic, I think was incredibly successful in engaging and retaining folks who had a challenge with care engagement and viral suppression. But again, in many settings, a model like that can be just, limited by resources and time.
And there's a question just asking about linkage to care early after infection. So is there anything sort of special about that period of time where you want to try to get people virally suppressed when they're first diagnosed?
Absolutely. So, I think, in the context that, and it's been a big push, it's amazing to see with rapid start initiatives and, just really pushing for when someone is, newly diagnosed, and again, being mindful of someone, taking on this new diagnosis, but really encouraging, connection to care and offering therapy early on, recommended in guidelines. I think especially true for folks, in the context of acute infection. I think we know in the context of acute infection, if we can start therapy earlier, we can limit viral reservoir and seeding, of other tissues. So I think overall there's been, a real strong push in guidelines recommending, when folks are initially diagnosed, to provide the supports and encouragement to engage in care as quickly as possible and start therapy, including, same day therapy. And that's defined differently, but that general premise. And again, I think, our data would suggest that for acutely infected people, particularly value in kind of that early care engagement and treatment.
Wonderful, thank you. Christina Manassian from Dartmouth Hitchcock Medical Center did ask, have the implications of mental health diagnosis on treatment engagement been studied? Are there specific diagnoses that impact or impair engagement more than others?
Yeah, no, this is a great question. And I think, through observational studies, have consistently shown that a myriad of individuals with different mental health diagnoses have greater challenges with treatment engagement. So I think this has been seen with depression, with anxiety, with PTSD, with substance use disorder, alcohol use disorder. Looking at the literature, I think depression has been the one that's been most widely studied, and a lot of interventions. So there have been interventions of, pharmacotherapy to treat depression, coupled with oftentimes medication adherence interventions, a lot of behavioral, interventions, including, cognitive behavioral therapy, and have shown mixed results. I will say, I think one of the things that I've been encouraged by more recently, a colleague, Brian Pence at UNC, studied, this kind of idea of, for many of our patients and people with HIV, there's co-occurring. I mean, someone has depression and PTSD and active, substance use disorder. So a lot of the studies historically were limited to kind of singular treatment for singular mental health diagnosis, and really didn't reflect the real world experience of a lot of our practices. And so promising model of transdiagnostic counseling. So based in cognitive behavioral therapy, but really not limited to. So I was able to work with someone who might have a different combination of mental health diagnoses, and in a small pilot study looked, very, very promising. So I do think models, that focus more broadly on the real world experience, that a lot of persons, don't singularly have depression or anxiety, but co-occurring conditions is going to be really important as we go forward.
Great. Then there's one last question I was going to ask you from Joseph Yao from the Mayo Clinic. Are there any electronic or mobile phone apps that you would recommend to assist with adherence and engagement in HIV care?
Yeah, I think that narrative review would be the best source. I think there's a bunch that are out there. I don't know that any of them have really hit the mainstream in terms of, really kind of getting a large number of practices using them. So I think that narrative review showed, 23 different interventions and a lot of different mobile health apps and interventions. To my knowledge, and if others know, please share. I don't know of any of them that have been so successful that they've really been kind of widely adopted and taken up outside of the context of research studies.
Yeah, it sounds like what you pulled out from that also was that the human touch is also an important component, so that the app or the tool itself isn't enough, that you need the human contact in addition to try to connect with people.
Yeah, I think that's right. And I think we're also in thinking about cost constraints and these idea of people getting called and two-way text. I think we're in an interesting era too now with generative AI, and almost could two-way texting be done in a personal way? I mean, through AI, and that then through a strategy of, if that wasn't an effective, again, personal strategy, could we trigger to a human touch and contact? But just thinking about some of the challenges of workforce and personnel and things, I'll be very interested to see, how generative AI, again, not personal, but simulates personal in many instances, and just what that might hold for the future of different studies. But yeah, I think you're right, Susan. Like this idea of consistently, the human touch with retention and care has always seemed to be a key ingredient.
Yeah, we use the WellTel system in a PrEP study in young men in Chicago, and what we found was that there's a component to WellTel that's an automated check-in on a weekly basis. How are things going? And people know that it's an automated check-in, but then they knew that they could respond that they had a problem, and somebody would answer that.
Right.
And what they
That's
said
right.
was that they felt really cared for, even though they knew there was an automated check-in, that the automated check-in helped them feel cared for, but that the critical component was also then being able to get a hold of someone
That's
if they
right.
did have a problem.
Yeah, that resonates. I remember years ago at the Adherence conference, someone presenting qualitative work, and the same thing. Someone said, like, I knew that the first thing was automated, but they named the person. I knew if I needed X, I could reach X, and just knowing that that person was behind it was really important. So I think, again, consistently, that seems to be a theme.
Yeah. Well, thank you for both a brilliant presentation and a very comprehensive discussion afterwards. We do have a few final slides that we want to show you. The first is just to remind you that you're going to be getting an evaluation, but that will be emailed by 5 o'clock Pacific time tomorrow. And it's very important that you answer that because your feedback is really important to ensuring that we have valuable content in our educational programs. We're very excited that we will be launching, IAS-USA will be launching in Topics in Antiviral Medicine, a visual guide to opportunistic infections in people with HIV. It's now available, and it's really quite useful and quite colorful. So please do avail yourselves of that. There's a Going Antiviral podcast that's hosted by Dr. Mike Sag, and the most recent one is a really blockbuster with Dr. Dimitri Daskalakis talking about the CDC without scientific leadership. So please be sure to tune into that. There is an upcoming webinar on solid organ transplantation in people with HIV on November 13th. And one on CMV suppression, improving immunologic and functional aging outcomes in populations undergoing HIV treatment, that's now available on demand. There's going to be an IAS-USA annual update on HIV management in Chicago on November 18th. So we do encourage you to register for that. And then 2 virtual updates: a medical management of people with HIV as they age, a course for non-geriatricians, and that looks really very exciting. And another one, emerging challenges in HIV medicine, that will be held on December 4th. So thank you all for participating. We're really pleased that you were able to join us today, and we look forward to your ongoing participation in other work of IAS-USA. Thanks for joining.
Thank you.